Welcome to the Explainer. Today, we're doing something a bit different. We're tossing out rote memorization entirely. Instead, we're going to build a mental framework to help you understand heart failure, specifically cardiomyopathy, from true first principles. By the end of this, you won't just be pattern matching. You'll actually be able to reason through the exact mechanics of a failing heart, kind of like a mechanic looking under the hood of a car. Let's get into it. Picture this. You're on a ward round and you've got two patients. Both are breathless, both have swollen ankles, and both their charts simply say heart failure. On the outside, they look absolutely identical. But beneath the surface, they're hiding totally opposite structural defects. Patient A's heart is this thin-walled, ballooned-out sac that can barely muster a squeeze. Patient B, on the other hand, has a thick-walled, muscle-bound fortress of a heart. It squeezes incredibly hard, but it's way too stiff to actually relax and fill with blood. These are completely opposite diseases that need completely opposite treatments. If you treat one like the other, well, you're going to make things a whole lot worse. So before we even try to classify the specific muscle issue, we've got to play the role of a strict gatekeeper. We have to ask the big fundamental question. Is this just coronary artery disease in disguise? Ischemic cardiomyopathy, where the heart is failing because the tissue is chronically starved of oxygen or already dead, is the absolute most common culprit. And it's mechanically fixable. This is exactly why every single one of these patients gets an ECG, serial troponins, and usually a coronary angiogram. We have to make absolutely sure the pipes are clear before we start planning the engine. All right, once we confirm those pipes are perfectly clear, we cross the threshold. We're officially dealing with primary muscle disease. This means the problem is baked into the myocardium itself. The engine is fundamentally flawed, not the fuel lines. From this point on, what we see on the echo, the wall thickness, chamber size, ejection fraction, that's what's going to tell us which family of primary muscle disease we're looking at. Now, here is the unifying master rule for this whole explainer. If you get this, you can predict everything else. When heart muscle fibers are under chronic stress, they add basic contractile units called sarcomeres in one of two geometric ways. If the sarcomeres are added end-to-end or in series, the muscle fiber gets longer. The wall thins out, the chamber dilates, and you get eccentric hypertrophy. That leads to systolic failure, meaning it just can't squeeze. But if those sarcomeres are added side by side, in parallel, the fiber bulks up. The wall gets super thick and stiff, shrinking the chamber. That's concentric hypertrophy, leading to diastolic failure. It can't fill. This single geometric response dictates the whole ballgame. Section 1. Dilated cardiomyopathy, or DCM. Sarcomeres added in series. DCM is the most common non-ischemic primary condition, and it completely follows that first rule of geometry. Because the sarcomeres are added in series, we get eccentric remodeling. The heart balloons into this huge enlarged ventricle. And the takeaway here is that this causes a predominantly systolic dysfunction. Think of the classic Frank Starling curve, the heart's built-in stretch reflex. In DCM, that curve is pushed way down into the right. The heart is stretched out, it's weak, and it's really struggling to squeeze forcefully enough to eject blood. So why exactly does the heart stretch out like this? Genetics are actually a massive driver. We're talking mutations in the TTN gene, which codes for titin. Titin is literally a giant molecular spring inside the sarcomere, so you can imagine what happens when that breaks. Then there are LMNA mutations, which you really need to look out for, because they carry an incredibly high risk of sudden arrhythmias, even if the pumping seems okay. But it's not all genetics. Toxins, like chronic alcohol abuse or anthracycline chemo, can just poison the muscle. Viral myocarditis or late pregnancy can also set it off. And here's the coolest part. If the DCM is caused by toxins or an uncontrolled fast heart rate, it can actually reverse and heal if you catch it early enough. Section 2, Hypertrophic cardiomyopathy, or HCM. Sarcomeres added in parallel. Okay, let's flip the geometry entirely. Because sarcomeres are added side by side here, the heart builds this incredibly thick hypercontractile fortress. It squeezes just fine, but it completely fails to relax. So we're dealing with diastolic dysfunction. Fundamentally, this is a genetic disease of the sarcomere proteins, primarily driven by MYH7 and MYBPC3 mutations. And this is a really crucial detail. It's inherited in an autosomal dominant pattern. That means the second you diagnose HCM in a patient, screening their first-degree relatives isn't just a suggestion, it's absolutely essential. Now, what happens when this thick muscle literally gets in its own way? Roughly 2/3 of HCM cases have an obstructive component, which we call HOCM. Let's break down the fluid dynamics here, step by step. First, the septum thickens asymmetrically, physically narrowing the left ventricular outflow tract. Next, as blood tries to eject through that tight squeeze, it speeds up really fast, generating a huge pressure drop known as the Venturi effect. And because of that physics phenomenon, the anterior mitral valve leaflet gets vacuumed violently forward into the outflow tract. We call that systolic anterior motion, or SAM. The end result? A total mechanical traffic jam. The outflow is severely blocked, and since the mitral valve is yanked out of place, you get mitral regurgitation at the exact same time. Connecting these physics directly to treatment makes everything instantly click. If you're dealing with dynamic obstruction, you absolutely want to use drugs like beta blockers or non-DHP calcium channel blockers. Why? Because slowing the heart down reduces the force that drives that dangerous Venturi effect. You can also use newer cardiac myosin inhibitors to directly calm down those hyperactive muscle fibers. But listen to this. You absolutely do not use standard heart failure treatments like vasodilators, heavy diuretics, or inotropes. Dropping the preload or boosting the squeeze will literally make the obstruction worse. It's like flooring the gas pedal while you're stuck in a traffic jam. If meds don't cut it, then you start looking at physically thinning the septum with surgery or ablation.
We need to pause for a second, though, for a really critical warning. Aside from the obstruction we just covered, HCM carries a totally separate and frankly terrifying risk. The cellular architecture in an HCM heart isn't just thick, it's extremely disorganized. This chaotic, messy arrangement of muscle cells is a leading cause of sudden cardiac death from ventricular arrhythmias, tragically often seen in young athletes. Because of this, assessing the risk for an implantable cardioverter defibrillator, or ICD, is a completely non-negotiable pillar of managing these patients, regardless of whether their outflow is obstructed or not.
Section 3, the outliers and rule breakers: restrictive, Takotsubo, ARVC, and LV non-compaction. First up in our rogues gallery is restrictive cardiomyopathy. What's fascinating here is that this is strictly a diagnosis of physiology. The ventricle is stiff, non-compliant, and fills poorly. But not because the muscle cells themselves got bigger. It's because of rogue infiltrators. Take amyloidosis, for example, where misfolded proteins deposit right into the tissue. This gives you a really classic weird mismatch. The echo shows a super thick wall, but the ECG shows surprisingly low voltage. That's because all that extra thickness is just dead protein, not electrically active muscle. You also see this with iron deposits in hemochromatosis, granulomas in sarcoidosis, or severe fibrotic scarring that practically cements the inside of the heart. Next, we have the ultimate structural outlier, Takotsubo cardiomyopathy. This isn't a fixed structural disease, it's completely functional. Basically, a massive emotional or physical stress triggers a huge adrenaline rush that stuns the heart. The base of the heart goes into overdrive while the apex just stops moving, creating this temporary ballooning that looks exactly like a traditional Japanese octopus trap. The crazy part? Clinically and on an ECG, this perfectly mimics a massive, lethal STEMI heart attack. You usually only figure out it's Takotsubo after you've rushed the patient to the cath lab and the angiogram proves the arteries are completely clear. Thankfully, it's highly reversible. Let's wrap up the outliers by briefly contrasting two really wild variations. First is arrhythmogenic cardiomyopathy, usually called ARVC. Here, a genetic glitch causes the actual heart muscle to slowly die off and get replaced by fat and scar tissue. As you might guess, that is a massive driver for severe sudden ventricular arrhythmias. Then you have left ventricular non-compaction. This one is an embryonic cork. Before birth, the heart wall just fails to compact normally, leaving behind a highly spongy, deeply trabeculated myocardium. Those deep, spongy pockets are the perfect spot for blood to pool and become stagnant, which drastically spikes the risk for dangerous blood clots.
Which brings us to the end. We kick things off by separating the engine from the pipes. We looked closely at microscopic geometry, sarcomeres adding in series versus parallel, to understand exactly why a heart either balloons out and can't squeeze, or bulks up and can't fill. And we saw how genetics, toxins, and random infiltrators throw a wrench into that system. So I'll leave you with this thought. Trust this new mental model. The next time you're staring down a complex heart failure case, one that maybe doesn't look exactly like a textbook presentation, can you use these simple fundamental rules of physics and geometry to deduce exactly why it's failing?